This is DC EKG, exploring the intersection of politics and healthcare by diagnosing Washington and prescribing solutions. We take a deep dive into the legislation, regulation, and innovation impacting policymakers, providers, and patients. Now, America's health policy expert, Joe Grogan.
Welcome back to DC EKG, where we run a political stress test on Washington, D.C.'s healthcare policy direction. Today, we're joined by Sue Peschin, President and CEO of the Alliance for Aging Research. We'll be discussing Alzheimer's prevention, detection, treatment, and most importantly, the policy and access questions that determine whether patients can be diagnosed early and receive appropriate treatment and care. We'll focus on where the system is currently falling short and what we need to be focused on moving ahead, considering where the science is going. So, Sue, thanks so much for joining.
Thanks for having me.
So let's start with the Alliance for Aging Research. What is it? What do you do? What have you been focused on? How old is the organization?
Well, that is a wonderful question because we happen to be celebrating our 40th anniversary this year.
Wow. Congratulations.
Yeah, thank you. The Alliance for Aging Research was founded in 1986, and we're really the leading organization dedicated to reframing the conversation about aging to improve healthy aging and access to care. That's our mission, and we do that through both health education and public policy work. And we work on a whole variety of issues, including Alzheimer's, which I know we're going to be talking about today. But we really look for gap issues where a disease-specific organization or even another aging organization isn't as focused on. And as you know, we get in the weeds, right, on the policy stuff. And really try to explain things in a way like you're talking to your mom or your aunt in simple and direct language so that folks can make their own decisions, because we're really about empowering older adults and their family caregivers to advocate for themselves.
How long have you been with them?
I started in 2012, and I succeeded the founder, Dan Perry, who's on our board today. And he started the organization back in 1986 because at that time, there was really no organization looking at aging as a way to improve health. The movement itself was mostly focused on direct senior services. And so the Alliance for Aging Research was really the first organization that said, we want research and we want funding for it at the National Institutes of Health. It came, a few years after the National Institute on Aging was started, and also focus and funding at FDA and the Centers for Medicare and Medicaid Services. And there really hadn't been that type of dedicated focus until that point.
Has your entire career been with the organization, or no? What did you do before this?
So I actually worked in gun control for 10 years.
Okay.
I also worked in women's health issues. I worked in cancer education for the Cancer Information Service right out of college at Dana-Farber Cancer Institute.
Oh, wow. Okay. So let's talk a little bit. The primary focus of the organization right now is Alzheimer's. Is that right or wrong? Or how broad a focus? Is it on a number of different issues, and Alzheimer's is but one of the issues you focus on?
Correct. Yes. I mean, we do work in Alzheimer's disease in both education and public policy. We do a lot of work on neuropsychiatric symptoms of dementia because, to be honest, the Alzheimer's disease specific groups don't do a lot on that. And neuropsychiatric symptoms like agitation, depression, anxiety, psychosis, those symptoms are really not talked about that much. They're highly stigmatized. And there's also some policies, in particular, quality measures in the Medicare program that really impact residents in nursing homes from being able to get effective FDA-approved treatments.
So the conversation is going to focus on Alzheimer's, but I am very interested in the other issues, if we have enough time, like the other psychiatric and mental health issues at senior space. If not, maybe you can come back another time and we can focus on that. Clearly, depression and mental health struggles are a big issue affecting all of America, different demographic groups and more pronounced in the post-COVID era. So that's an important subject, maybe for another day if we don't have time today. But talk a little bit about the size of the Alzheimer's problem in the United States, if you could, in plain English to people. How many people are we talking about that are diagnosed? How big a problem? How many undiagnosed? You know the rigmarole.
Absolutely. So there's an estimated 7.2 million Americans, primarily ages 65 years and older, who were living with Alzheimer's disease in 2025. And about 74% of them are age 75 or older. So Alzheimer's disease is primarily a disease of aging, and aging is the biggest risk factor for Alzheimer's. And the percentage of people with Alzheimer's disease understandably increases with age. About a third of people age 85 and older have Alzheimer's dementia. There are people younger than 65 who also develop it, and this is becoming, more common. There's more awareness around it. The the data on that is a little bit more limited. But it's estimated to be about 110 of every 100,000 people between the ages of 30 to 64, or about 200,000 Americans total that have what's known as younger onset dementia.
And is Alzheimer's one disease among a constellation of dementia-related illnesses that affect seniors, and this percentage of young people 30 to 64, or is it a catch-all term for all senior-affecting dementias?
Yes, dementia is the broad term. Not all dementias are Alzheimer's. Alzheimer's is the most common type of dementia, which is why we talk about it more than other types. But other types are getting more play and more awareness in the public and then PR, in the press. Frontotemporal dementia, Lewy body dementia from, celebrities that have had those diseases. They can accompany Parkinson's disease. There's also vascular dementia. And oftentimes when people have Alzheimer's disease, they also have vascular dementia. Most people with Alzheimer's have a mixed type of dementia.
So when you say vascular, that's a lack of blood flow to the brain, and that causes dementia, or even does it sometimes cause psychosis or other confusion, or am I tracking that right?
Yes. Yes. I mean, you could have I think most of the time, a lot of people associate Alzheimer's or related diseases with cognitive issues, like you can't remember things.
Yeah.
But behavioral and psychiatric symptoms, which are also known as neuropsychiatric symptoms, are just as, sometimes even more common, and sometimes they occur prior to the cognitive decline that people experience. And so, yes, I mean, you're exactly right. You can have those symptoms along with the cognitive decline that's much more well known.
Why is it important to get people diagnosed with Alzheimer's? And the number you gave was 7.8, did you say? 7.8 million?
7.2.
7.2. I'm sorry.
Yeah,
are they diagnosed, or is that an estimate?
That's an estimate.
Okay.
So a great number of folks, it's still said in the literature that about 50% of cases go missed in the primary care setting.
Wow.
And there's a couple of different reasons for that. I mean, some of it is a lack of awareness. I mean, we now do have treatments, but it's only been in the last couple of years that we've had these FDA-approved disease-modifying treatments. The ones before that were symptomatic and did help delay slightly cognitive decline. And they even helped a bit with the neuropsychiatric symptoms, but it's been a long time. And the very first disease modifiers were approved in 2021, the very first one. And it was a huge breakthrough and very exciting. But a lot of physicians are not up to speed necessarily, or they might have some skepticism. There was really a widespread effort, I think, in the press to try to say these aren't good treatments, or they're very dangerous. And they're not. They're good, effective treatments. They're early. They're the first line treatment. With cancer, oftentimes we have 4 or 5 options, that you fail through, and there's still another option available. So Alzheimer's disease clinical development is not as far along, and so this is a huge cause for celebration. But adoption, by the clinical community, has been gradual over the last couple of years. But detection is critical, regardless of whether or not you're eligible for the new FDA-approved treatments, whether they be for the disease-modifying therapies or the neuropsychiatric symptoms, because there are 2 of those that are available for Parkinson's psychosis and one for Alzheimer's-related agitation. Even if you're not eligible for any of those treatments, it's reasonable to be diagnosed as early as possible, so that for a couple of different reasons. One is there's a lot of other things that cause dementia-like symptoms as we get older. Everything from having shortage of, vitamin D to a thyroid problem to, medication mix-ups that are causing dementia-like symptoms. So it's important to get it checked out just for that alone. And then if you do end up getting diagnosed, you want to be able to plan with your family and understand what's in front of you and get access to resources as soon as possible. And to see if, any of the medications or care strategies would work for you and your family, and to alleviate some of the burden that comes along with these diseases. These are not easy paths, and we need to do a much better job of promoting early detection and intervention for folks.
Yeah, I feel like there was this, because I cut my teeth in the HIV policy back in the early 2000s in the Bush administration, and there was this tail on that policy from the 80s and 90s, which was, there's no effective treatments for HIV, so why even bother getting people diagnosed? Now, there were all sorts of public health reasons that got insanely politicized, I felt, about getting, diagnosed. And also, there was also this bizarre paternalistic view on the part of some people in the public health community, like people are too dumb to understand their diagnosis. They're all going to go out and throw themselves in front of trains. This is miserable. There's no hope. We shouldn't tell them what their HIV status is. And then the new treatments came online, but it had a long tail. And convincing people to get diagnosed early, and then the science caught up with getting people treated early and getting viral suppression and everything. It kind of feel like it's analogous with Alzheimer's, the fact that there were not a lot of treatments. And we watch company after company burn through, hundreds of millions of dollars going after Alzheimer's as a target and not getting it. And then we saw our first treatment. There were all these wild cost estimates that were totally absurd, as you said. And again, you mentioned the media going out. I'm going to say it a little bit more impolitic. I think there was an active movement on the part of people who didn't want to pay, organizations who didn't want to pay for these drugs, to disparage them and attack the integrity of all these people involved in the underlying science. And then even the first one, there's been advances in that class and amyloid plaque inhibitors. And just again, to be self-indulgent, but I watched the same thing happen in hepatitis C when I was involved in that breakthrough. There were people who came out and said, we don't know that these treatments work. They don't know if it's really going to cure anybody. It's just going to suppress the virus, and then it's going to pop back. They're going to go out and shoot up again or have unprotected sex, and everybody's going to end up with HCV. So we shouldn't pay for these treatments. Meanwhile, they're probably the most significant medical breakthrough in any disease area of the last, since antibiotics or something. I mean, they were so good at first with Gilead and then and Merck and AbbVie. But there was this disparagement of the underlying science. And we'd go in and talk to state Medicaid directors and they would say, oh, we don't think these things work. And there's something going on here of the same sort, in my opinion. I'm wondering what your reaction is to that. Do you see this type of vilification and an active coordinated effort to vilify the drugs?
Yeah, I mean, I think everything that you said is spot on. And I would add that when payers are not used to having to cover something, they're really resistant. So this is the first disease-modifying therapy, right? The first class of disease-modifying therapy. So they've been paying for cancer treatment for a really long time. There's an understanding that that is a high-cost condition. Alzheimer's has always been a high-cost condition, but it's primarily fallen on families, for personal care and for long-term care and the Medicaid program. And Medicare tends to fall in third place. So when these treatments came along and became Medicare's problem, and also a potential volume problem, because it was estimated that as many as, 1 million beneficiaries might eventually qualify for this in early Alzheimer's disease, they hit back hard. And I agree with you that that's what we saw. I think it has long-lasting impacts on how people trust science, on how people trust the FDA. And I do think it raises questions about what is the role of payers in questioning safety and efficacy, and how is that really contributed to loss of trust in the FDA and in science itself.
Yeah, I'd even go back I want to go back even further. I mean, they even, as you spoke, I mean, I should have said this, but they did the same thing in HIV for the treatments in the protease inhibitors. They said, these things don't work. We don't think these things are going to work. It's an old playbook on the part of people who don't want to pay for cutting edge medicines. And it's, one unfortunate feature of American healthcare is that the drug spend is on one side of the ledger and the care side is on the other side of the ledger. And then, of course, off the ledger, to your point, is the family expense associated with getting a nurse or taking work off or getting some type of home assistant to watch a family member or put somebody in an institution where they can get care, because this is not a simple endeavor to take care of somebody with Alzheimer's dementia. It's certainly a really expensive problem, but like I said, it's a different part of the ledger.
Right. And because they were so used to paying for cancer therapies during the period of time when the Medicare program initially heavily restricted coverage for the new Alzheimer's therapies, they were expanding coverage for the cancer CAR T therapies, which are anywhere from 500,000 up to 1 million per case, because there's a lot of adverse events, and those are fourth, fifth line therapies for people who don't have other options. And they expanded it from hospital administration only to outpatient administration. So it's not as though there weren't resources available. It's cherry picking. And it's doing it based on volume, political power. And we think both. I mean, we would like to see both. I mean, we're certainly not against cancer patients getting the treatments that they need. But you can't just it's like you pick the wrong card.
Right.
And too bad.
Sure. So if you think about it, like misimpressions, misunderstandings, you are in the advocacy business. You obviously probably at just about every cocktail party you go to, somebody will ask you about Alzheimer's or family gathering. I shouldn't act like you're just going to cocktail parties. Sporting events too, when people find out what you're doing. What's a common misconception or the most common misconception about Alzheimer's disease, do you think?
There's a lot of misconceptions. I mean, there's certainly misconceptions about the FDA-approved therapies. They don't do anything. They're super dangerous. That we already, I think, ran into the ground here talking about the coordinated campaign against those therapies. I think overall, there are misconceptions with neuropsychiatric symptoms that it's something that the person should be able to control, or that the family caregiver should be able to use, non-pharmacologic interventions to lead the person away from thinking psychotic thoughts. And if they're not able to do that, there's something wrong with the way that they're caregiving. You should never have to use medication.
Really? People think that, because I mean, unfortunately, I've seen seniors with dementia have these psychotic episodes, and I've watched, their personalities are totally different. I love one who was kind and sweet their entire life and generous, and a model mother or father or uncle or aunt. They can have these episodes. They're complete, but people think that this somehow can be, they haven't had that experience, so they think you can somehow moderate their behavior and control it by what? By painting the walls a soothing color and playing Mozart or something? What do people think you can do here?
Well, I mean, to be fair, there are things that should be tried before medication is used. And also neuropsychiatric symptoms tend to worsen over time. So I'll give you an example. I mean, my great-grandmother had what they used to call senility, right, in the 80s.
Right.
And she had hallucinations that Hitler was in the building, in the nursing home where she was. She was actually in the Jewish home for the aged in Pittsburgh. And we used to joke in our family that if Hitler was going to hide somewhere, hiding in the Jewish home for the aged in Pittsburgh, that would probably be a good choice. And my mom, before what they call validation, because I mean, the advice, and for your listeners, is always a good thing. Don't spend time trying to correct. It's very common to want to correct your loved ones. And as long as they're not saying stuff that is dangerous to themselves, scaring themselves, or inappropriate, to other people around them, or things like that, just let them go with their story. And my mom knew validation, just understood that was what we should do. So we would just tell her, "Oh, Hitler, went out to lunch, and he's not here right now." And for a little while, she would believe that.
Right.
But over time, it did get, so there are, things that you can recognize. Maybe the person, if it's a case of agitation, they're uncomfortable. Maybe they have an infection, things that they don't know that you should check for. So if there's discomfort, if there's interruption to their routine, there are non-pharmacologic strategies that you can use. And we have a lot of this on our website at agingresearch.org. Where we talk about, depending on what your loved one's experiencing, different symptoms, and we have videos on this and all that. But over time, in the 80s, that was when they used Haldol, shots of Haldol. And I think that there's this perception that somebody just gets a little upset and it makes a caregiver uncomfortable. And that's why everybody's going to all these medications that aren't needed. Well, when my great-grandmother was really deeper in psychosis, she would thrash around. She was 89 pounds wet. We were worried about her breaking something.
Sure.
She would soil herself. That's how upset she got. So it doesn't preserve dignity to just say, well, you should be able to figure out a way to handle it. And she couldn't get a hold of herself. That comes from a degenerative disease in her brain. And so it was alarming, definitely, to see her given a shot of Haldol. And I'm glad that there's other types of medications today, but it saved her from injuring herself. So when people say you should never have to use an antipsychotic or this or that, I always ask, have you actually had direct caregiving experience? Because it's easy to be, I think, high up in the seats. But if you haven't, been in the arena as a caregiver, it's a very different experience. And I've seen people change even at CMS, who have now had those experiences, and they're finally like, they have a loved one in a nursing home and they say, I get it.
Yeah, I mean, it's so difficult to watch a family member's personality change and psychologically damaging to the family, to hear a parent or somebody, the sibling, or be like crazy abusive and nasty and terrified and not recognize them. And you're like, what, you can't like turn that off, right? Somebody you have known your whole life and loved you is now saying you're a terrible person or you're in league with Hitler or whatever, whatever example you want to say. It's really tough on the family members. And I guess I can see how people would not believe how bad it could be and how hard it
Right.
would be and fall into the delusion that it can be controlled without medication. Okay, so now, like when you look at it, we talked a little bit about early detection, we talked a little bit about the treatments, but across this continuum, where are we as far as what does Sue Peschin want to see as far as bottlenecks cleared up? Do we need more diagnosis and detection? Do we need more diagnostics approved by the Food and Drug Administration? Of course, everybody wants to talk about AI. I mean, are we seeing AI tools getting developed to detect people at risk of Alzheimer's and if they actually have Alzheimer's? And then the treatments. And where do you see these bottlenecks to getting people? Oh, and the underlying science. I mean, you mentioned these are the first wave, these amyloid plaque inhibitors are the first wave of Alzheimer's. I'm throwing a lot at you, but the first
That's
wave
okay.
of treatments, but hopefully there'll be new and better treatments down the road. So where
Yeah.
are we in all this as far as your focus about what needs to be improved for Alzheimer's patients?
Yeah. I mean, I would say, there are friction points in just about every step of, the path right now for both patients and family caregivers. So we talked a little bit about detection. There's also a lot of, I think part of the friction comes from the fact that there has been movement forward with the science and also with FDA approvals, both for detection and treatment. And that does create friction as we talked about with HIV/AIDS and these new therapies. So, primary care doctors have to rethink, their time in terms of whether or not they have time or the capacity to do testing. There's a lot of demands on primary care and, squeezing it into as part of the annual wellness visit. There is detection of any cognitive impairment that's part of the wellness visit. Not the easiest thing, but encouraged. And that was a breakthrough that I actually worked on prior to coming to the Alliance. I was at the Alzheimer's Foundation of America for a number of years right before I came to the Alliance.
So what does that look like? The dumb question, but what does that look like? I'm 60 I'm 60, whatever, 62, and I'm going in for my welcome to Medicare exam or my annual checkup. What does that screening test look like for Alzheimer's?
Yeah, I mean, there's several screening tests that are up on the CMS website. So docs have a couple of different choices, and they're usually short cognitive tests that can just indicate whether or not, to be honest, you need more testing or maybe a referral. Writing a clock, at a certain period of time. They ask you for a date. They might ask you to remember a couple of words and then wait 5-10 minutes and ask you to recall those words. So that's what that looks like. And that's to really get a baseline and find out whether or not you might need just a little bit more exploration. What I mentioned before is, first and foremost, want to find out, does the person have a UTI? Do they have, a thyroid issue? Or, what are other factors in their health that might be contributing if they didn't score so well?
Right. But it's not like a blood test. You don't take a blood test
Right.
and get told
Yes.
you have Alzheimer's.
Well, there are blood tests now, but these are new. And the uptake, we need a lot more, I think, support for the blood-based biomarkers that have come along. There are two that have been cleared by the FDA that are Alzheimer's blood-based biomarkers. One that can actually help rule out if you have Alzheimer's in the primary care setting, which can help ensure right people are progressing to additional testing. So it's a good rule out test. and another that helps to confirm Alzheimer's pathology in specialty settings, so neurologists, for example. And that can help replace the need for something that might be more invasive or more expensive or restrictive, like getting a PET scan or getting a lumbar puncture, which is a spinal tap. And there are also new digital cognitive assessments that are becoming available that can help detect or confirm cognitive impairment symptoms. So there's a lot happening in the detection space. And there is some tension between, does this have to happen in specialty care? Eventually, we're going to need it at some point soon, I think, in primary care, because there just aren't enough neurologists, and people might be waiting anywhere from 12 months to 18 months to get an appointment. And that's just, time goes by. Time is really the most important thing. And if you're going to get one of these newer treatments, you only have so much time in order to do that.
When you said the digital diagnostics, so that I'm sitting in front of my computer and I'm getting asked questions, and that helps inform whether or not I have Alzheimer's or not. And I would think that this would be a ripe area for the AI assisted screening tool at home or in a primary care physician's office that would diffuse this whole screening, funnel or something like that, widen the funnel. I guess that's the analogy I'm looking for. Is that fair? Or?
It is fair. And the wellness visit can be performed by a lot of folks at different levels in the doctor's office. It does not have to be administered by the doctor. It's actually it's a pretty wide scope of folks who can do it. So you could have iPads, in the waiting room. Folks, can look at that. They're not always, word questions. Those are typical screening tools, but there's also ones with pictures and what do you notice that's different. I definitely want to caution folks against things you might find on Instagram or other types of, so there's a lot of that today.
Right.
And to veer away from these, the supplements that are online and all that kind of stuff. Everybody's really concerned about this. Best thing to do is really go in, if you're in the Medicare program, have your annual wellness visit, make sure that this is a part of it, it's covered, and, just find out how things are going. And there is also age-related memory loss, right? The big joke I think you see a lot now is when you go into a room, I hope you remember why you went there.
Yeah.
And people think, oh my God, I'm starting, and so I think it's also just to understand that the worry is not so much why did you go into the room? It's more when you don't understand what the room was for. Or you sort of lose your sense of place in general. So there are differences in kind of understanding what is also normal cognitive loss. But there's a lot of new things on the diagnostic front that are very exciting, and I think there's a lot of room for advocacy around it. The coverage issue is a big issue that we are working on, and I'm sure you followed, the MCID bill that just recently passed for multi-cancer early detection. Something very similar for Alzheimer's, for these blood-based biomarkers to bypass the USPSTF process, called the ASAP Act, that would provide Medicare coverage. That it's needed to have this happen a lot faster.
So where are we on the ASAP Act? Is that a notion, or has it made it through committee, or has it been passed by one of the houses of Congress, or what's the deal?
It's been introduced.
Okay.
And there, is growing support for it. And, a number of organizations support it as well. And it's something that I think, especially on the heels of the MCID Act, we need to sort of open up this conversation of like, why do we now need to legislate all these screenings,
Because we erected a structure that is deliberately bureaucratic as a barrier to access. That's why we did it. And we wanted to take power out of the hands of physicians and patients to say, this is what we need. Right? I mean, that's why we need it. So in classic American fashion, rather than rip down that that screwed up process. We're building exceptions to the screwed up process on a disease specific basis.
Yeah. And we think we have a good case to make because with the restrictions on the available treatments, don't stand in the way of people finding out whether or not they have this condition.
Right.
And this is easier. And in the end, it's less expensive than trying to go, you may not need a PET scan or a lumbar puncture. So it's a lot less expensive in that regard. And let's also take a look at who ought to be able to prescribe them. But this is a great piece of legislation. Chairman Buchanan is the lead in the House. We're thrilled just to see this introduced, and we're going to fight like heck this year to get it over the finish line.
So that's Vern Buchanan from Florida? Mm-hmm. Is that okay? Mm-hmm. And I think he just announced he's retiring, unfortunately, but you have somebody to pick up the baton. And are there Democrats on the bill too?
There are. This is bipartisan. Tonko, I believe, is the lead. And it's a good legacy bill. I think this is a good year for the ASAP Act. So let's do it. Okay.
So then we got to get the ASAP Act done in your perspective. Now, looking out 3 years, you've got 3 more years of the Trump administration and then a new administration. So in my experience, advocacy groups like you got to think in terms of 12 months, the 2-year cycle for Congress, election, 6 months, 18 months, 3 years, 5 years, 10-year projects down the road. So let's talk about this 3 years. We talk about the next 3 years. ASAP Act is in there that you'd like to see get done. What else do you want to see for Alzheimer's patients to occur? And do not be limited just by, say, executive branch actions, but Congress and the executive branch and maybe specialty groups. I don't know. What do you want to see happen?
Yeah, we got to get rid of coverage with evidence development in the Medicare program. And just walking that back, for the monoclonal antibody drugs, this is basically a utilization management tool that CMS created on their own. It was not legislated by Congress. They created it. It started in 2005. And they've applied it primarily to diagnostics, including screenings like lung cancer screening was under CED for a long time, and medical devices. It's a way to control access to those therapies and ultimately the cost to the program, oftentimes for years, more than a decade in many cases. And they put coverage criteria, really heavy coverage criteria around the coverage determination, offer national coverage, which sounds great on its face, right? There's no different standards depending on where you live, but it may restrict by the location where you can get a therapy, who can give the therapy to you, the constraints around that might be much more narrow than the FDA approved label for the therapy. And that was something that CMS accomplished with the monoclonal antibody therapies, and it was the first time that they did it successfully for a class of medications. And they had been wanting to do it for a while. They actually tried in 2019 with CAR T therapies, but the cancer community pushed back hard. And they were successful by 2022 in doing it with the Alzheimer's therapies. But Robert Charo, who I believe you know,
sure.
In the
former
first,
general counsel of HHS,
yes, in the first administration, Trump administration, wrote a memo in the closing days of that administration saying that CED is not legal. CMS did make this up, and they didn't even make it up that well. That there were holes in it, pretty big ones. But they, in the last administration, really doubled down on coverage with evidence development to try to shore it up, try to fill some of those holes. And it is quite strong now and not easy to get through. And so what does that mean for Alzheimer's patients? It's estimated less than 20,000 patients since 2022 have gotten access to these monoclonal antibody therapies out of a potential million that could qualify.
Can we pause there for 1 second, Sue? I just want to make sure that we're tracking. So 7.2 million people may have Alzheimer's, but not all of those are diagnosed. That's just the estimate. Now, 1 million people, based upon the clinical criteria, could be eligible for these amyloid plaque inhibitors. That's like clinically they may be eligible. They'd have to be or they are eligible.
Well, that's the estimate of people that have mild cognitive impairment due to Alzheimer's or early stage Alzheimer's. And that's the labeled population for the class of monoclonal antibody therapies.
Okay, I'm sorry. And because of CED, only 20,000 people have gotten the treatments.
Yep.
Right. Can I take a philosophical thing? I just want to go on the philosophy, because we talked about, as sort of being snarky, but I actually believe that's exactly how these things work, which is the government creates something bureaucratic and then we try and find exceptions for it rather. The same thing with CED. CED was created in the Bush administration by Mark McClellan, and I believe he genuinely believed this will speed therapies getting covered, especially medical devices at CMS. The problem is somebody with his energy and insight then leaves and it stays with the bureaucracy. And CMS they have two major cultural issues at CMS that I do not believe can be altered. Just like, the scorpion is going to sting the frog. One, they are always going to second guess FDA's science. It is impossible for them not to second guess FDA. It is just the nature of the bureaucracy at CMS. They are going to say, we want to second guess FDA. And I think some of it is jealousy, frankly. They don't like all the contact that FDA has with industry. They don't like all the exposure to the cutting edge science. They don't like all the attention FDA gets. And so they feel just in their intestines, they're going to second guess that. The second thing is cost. They're not set up to say, we're going to speed therapy to patients. It's just not in their culture. They have a bureaucratic process for determining coverage decisions. A lot of people make an assumption that just because it's approved by FDA, CMS will cover it. For drugs, that is mostly true. But to your point about the Biden administration shoring up CED, they also put the amyloid plaque inhibitors the first time a drug had been put under a broad CED like this. Right. And they really broke through a barrier to try to control costs, again, with all these trumped up cost estimates of how much it was going to cost. And they succeeded brilliantly in restricting access to the drugs.
Right. They blamed raising premiums on how many people were going to get access to these medications and how much money they were going to have to spend, which was not true at all because of how limited it's been. It's barely made a dent.
Right.
But that has hung out there. And how horrible is that? That was the very first time that was ever done, where a disease area was called out and blamed for a rise in premiums. Shame on them.
Right. It was ridiculous. It was so mired in politics that it really was an unfortunate episode. Okay, so I've gone on my rant on CED, which I always love going off on CED regardless of the context because, and I always love going off on CMS second guessing FDA as an FDA veteran as well. As much as I respect the people at CMS, having spent a couple of years at FDA, I firmly believe it's FDA that should be making these decisions and judging the science, and we should have a separation between cost and safety and effectiveness, that those are two different areas for a lot of reasons, and they should forever not be conjoined. And CED is being used to conjoin them.
If I had a wish list and I could choose one thing for a change, one is let's get Robert Charo's administrative memo on CED back up. There have been a number of administrative memos that have been posted on the HHS website this administration from the first administration. That is not one. So I ask HHS, please re-up that memo.
Okay.
And then number 2 is just creating awareness that the very first provision in the Medicare Act, Section 1801, prohibits the program from interfering in clinical care. And arguably, that's what this is doing. But it has not been challenged that way. And I think that's something that should be explored.
I like them. I like both those things.
Okay.
I mean, we can spend all day just talking about CED and going through various examples, but I do think that the amyloid plaque inhibitors is by far the most egregious in CED. It's a real problem. So if people, are you on Twitter or X, I suppose? I mean, how do people figure out what's going on? Do you have a website? If people are interested in Alzheimer's, what do they get on your website? Where should they go if they're worried about a family member, them personally? And then if they want to get involved in the various policy fights that you are involved in, what do they do?
Absolutely. Thank you. Come to agingresearch.org. Email us at info@agingresearch.org. We have a whole variety of materials, both if you want to get involved and activated in public policy, as well as to educate and support. And we're happy to provide both. I am on social media, very active, LinkedIn, at Sue Peschin, on X, on Facebook as well, all that.
And Peschin, just for those people who don't know how to spell it, Peschin, Sue Peschin.
Right. Yes.
So, Sue, I want to thank you for coming. This is great. Your wealth of knowledge and experience, and you certainly taught me a few things. So it's good to see you again. Thank you.
You too. It's good to see you too. Thanks for the opportunity, Joe.
I want to thank Sue Peschin for being our guest and sharing her insights. This episode was sponsored by Survivors for Solutions and produced by Stay on Course Studios with executive producer John CZ Swartacki. Follow DCEKG on Spotify and Apple Podcasts for more conversations on healthcare policy and reform.